Thank you, Jeremy, for such a kind introduction. I also want to thank Dr. Yip from the Hong Kong Ophthalmology Society and the All Indian Ophthalmic Society for the opportunity to present at this meeting. And so the title of my presentation is that of surgical management of the myopic complications, particularly in relationship to the macular hole associated retinal detachment. You already hear enough about the myopia, and you can see pathological myopia is associated with quite a number of posterior segment complications. And I'm going to highlight the last two, the myopic foveal schisis and the macular hole, because these two conditions are actually interrelated. In terms of the etiology of myopic foveal schisis, you thought that the kind of outward progressions of the posterior staphloma as the myopia progressed, creating an outward traction or vector force, while the inner layer of the retina, such as the internal limbic membrane, epiretinal membrane, or even the vitreous on the surface, kind of taut and keeping it from migrating or moving. So these two opposing forces are creating the schistic formations of the macula. And you can see in the OCT the changes there. And when you have a macular hole, they tend to be stable in non-myopic patients, and they can be stable for months and years. On the other hand, in cases where there is high myopia, then the tangential tractions on the surface with the posterior staphloma, as the case that we just look at the formation of schisis, it actually allows the retinal detachment to occur. In addition, you also can have tractions on the retinal vessels, and that, as in this OCT, showing the tenting effects of the inner retinal surface. The purpose of staging the foveal schisis actually is trying to figure out which particular forms of foveal schisis, myopic foveal schisis, has the higher risk of progressions. As you can see, those with the entire macular schisis or the entire macula with involved with schisis has a almost 40% progressions. So these are the group of patients that you will want to pay more attention to. What's interesting though is that once the tractions on the surface relieve, whether it is a mild degree of schisis or very severe forms of schisis, the schisis will settle. So we know that then the vitreous tractions play a very important role in the formations and the maintenance of the foveal schisis. It's important to know that immediate surgical interventions is usually not necessary with patients with macular schisis, especially among those patients that does not have any detachment or macular hole involvement. However, patients with extensive macular schisis, as we saw in the stage 4 types, a progressions to retinal detachment can occur. So a removal of those tractions is important in order to allow complete resolutions of the macular schisis. Another interesting feature that has been highlighted by one of the publications is that if you developed outer lamellar changes or outer lamellar hole formations, it is actually a risk factor for the development of retinal detachment among those patients with myopic schisis. So if you see early changes in the outer retinal layer with the separation of the outer retinal layer from the underlying RPE, this is somebody you may want to pay early attention and consider early surgery because they are at risk. Here are just comparison between a macular hole with just cystic changes at the edges with no other sciatic changes. And this kind of macular hole will tend to stay stable for months and years. On the other hand, when you have sciatic changes associated with macular hole, they are likely to develop into retinal detachment, and it's not because of the surface tensions or tractions that's creating the schisis. Those tractions will certainly progress and causing more separations and leading to retinal detachment. So the surgical indications highlighted here, besides being symptomatic, is if you have a macular hole with retinal detachment, or if you have even just a foveal detachment, those are one that you want to do surgery because those are the ones that will progress. The surgical goal is to remove the entire kind of inner retinal component that are consistent of the vitreous cortex, the epiretinal membrane, and the ELM, because those are the tractional force that's keeping and maintaining the separations of the schisis. And it's important to remember sometimes there's also tractions at the retinal vessels, and so those need to be attended to, otherwise they can lead to recurrent retinal detachment. Other people have suggested you might want to consider treating the posterior staphyloma. What does it mean? Well, they suggest that by using a macular buccal that will lift up the posterior staphyloma, by pushing them in, that will relieve the tractional force that's caused by the structural deformity of the posterior staphyloma. For the surgical procedure, whether it will be a foveal schisis or macular hole is essentially the same, the vitrectomy and removing the tractions. For the macular hole, some people suggest to use inverted internal limiting membrane flap, or sometimes using autologous internal limiting membrane transplantations. And when you don't have any of those membranes, you can consider using lens capsules and sometimes autologous blood to try to fill the hole. But this may not be very effective in the case of a very bolus detachment. Here I'm going to share with you a case of a bolus myopic macular hole. You can see there is a fair amount of vitreous remain and this subretinal fluid streaming through a very small macular hole. The peripheral retina was inspected. There is actually no retinal tear in there. I want to highlight here, when you try to peel away the cortical vitreous membrane on the surface in a very bolus detachment, we need a bimanual approach. You can see those are not ELM. They are actually condensed cortical vitreous. Once you have that peel, you stained the internal limiting membrane, and then that should be peeled away. This happened to be a very small macular hole, so I didn't think it's necessary to do the internal limiting membrane flapped. So again, peeling it with a single instrument is difficult when you have a very mobile bolus detachment. So a bimanual approach will be a much more effective way to peel away the internal membrane as well as the epiretinal membrane. And for this particular case, the intention is to peel the membrane completely away from the macular surface rather than trying to create a IM flap. Then the next question will come along is how you're going to drain the subretinal fluid. Because if you drain it through the macular hole, there is a risk of that macular hole get enlarged. So in this case, you'll see later on that I decided to do a drainage from a extramacular retinotomy site. So a small retinotomy was created, in this case, just outside the inferior arcade. So under airflow exchange, you can see there's a tiny little hole that was created. And most people probably would do it superiorly. That probably would be a better choice. I think there must be something there at the time that prompted me to use that site. And once the fluid is drained, then gas-air exchange was performed. Oops, we'll go to the next one. So here, showing that in some of the larger macular hole, a inverted IOM flap may be helpful to help to close the hole and finish the detachment. The surgical complication can occur, particularly in the case of macular foveal schisis. Up to 5% of the cases can develop macular hole. So that's important to recognize these complications. And usually the risk factor for that is when they have a very thin inner retinal layer in the schisis or very stretched fovea. And the macular hole with the macular detachment, the important thing is to relieve all the persistent tractions. And the closure rate with the surgery, if you completely manage the retinal tractions, is quite good, and it's about 40 to 50%. The poor prognosis factors are long axial length and poor preoperative visual acuity. Just a brief mention of macular buccal, and you can see
Sorry to interrupt, sir.
Yes.
We are just up with the time, and I would just like you to conclude with the slides quickly.
I will, yeah. So, so here is the macular buccal, and it was put behind and indent the and push in the macula so that to change the vector force, and it reported about 70–80%. And here are some of the limitations for the buccal, and mostly because you require very good surgical precision in order to do that. Finally, I think the take-home messages for this management is that usually it's immediate surgical intervention for macular schisis is not necessary unless they are associated with a macular hole detachment or actually a presence of retinal detachment. And those macular hole that have retinal schisis have high likelihood of retinal detachment. Vitrectomy is the first option and has a success rate up to 70 to 90%. Macular buccal has a limited indications, require a good surgical skill. And thank you for your attention.